Mr. Firmpas, assistant professor in Demokritos University of Thrace, and my colleague, Mr. Peric, Dr. Peric.
Yes, I am Dr. Alexander, Medical Academy from Belgrade, Serbia. Welcome to this very interesting and relatively controversial session. And the first topic, Eliza, from the Poland, by Eliza Brożek-Mądry.
Will you please step up and show us your work?
The topic, auto mutilations, yes?
Okay, we can have it. It should be video.
Unfortunately, the first one has not joined yet. So we don't want to waste our time and have time for questions.
Good morning, everyone. Turn it on. Good morning, everyone. My name is Eliza. I'm from Warsaw Medical University, and I would like you to join me for this, well, let's say, rock and roll part in rhinology. And I welcome all of you who are interested in listening to this part of the session. Before I go further, I will explain shortly the term automutilation. What is it? And in other words, it is non-suicidal self-injury, and it includes behaviors such as cutting, burning, carving the skin, or purposeful self-battery, banging, bruising, and involves actions that are not supported by cultural practices or aesthetic purposes, which is why tattooing, piercing are not typically considered non-suicidal self-injury. When combining automutilation and rhinology, we receive some terms. And these terms are rhinotylexis, rhinotilexomania, and there's also trigeminal trophic syndrome. And rhinotylexis is a Greek combination of a nose and a habit of picking, while rhinotilexomania is obsessive habit of picking the nose. And we also have this trigeminal trophic syndrome, usually involving the Aller region, but I will discuss it later at the end of this presentation. What is rhinotylexis? Though stigmatized, there was this study back in 1995 showing that almost all adolescents and adults do it, and even the books were written on that. Being the most common self-manipulation, rhinotylexis is not considered to be pathologic unless it becomes obsessive. But there was found a positive correlation between nose-picking habits and nasal carriage of Staph aureus. This transmission is even increased 40-fold when the host is co-infected by rhinovirus. Professor Witzke-Fockens wrote this paper that in our patients, in ENT patients, the nose picking was associated with a higher burden of Staph aureus. And nasal colonization was found more frequently noted in people with certain diseases, such as HIV infection, obesity, diabetes, or granulomatosis with polyangiitis, and others. Yes? Nasal Staph aureus carriage in GPA has been found to correlate endoscopically with endoscopically proven endonasal disease activity and a higher relapse rate. However, the study also found that relapses in GPA patients do occur in the absence of Staph aureus positivity, as well as upon prophylactic antibiotic treatment.
We have a technical problem.
Yes, there is a problem. Yes, there is a technical problem.
Μπορείτε να το διορθώσετε?
So for a while I'll talk about Staph aureus, but later on I'll go to this obsessive compulsive problem with rhinotylexis, which is called rhinotylexomania. I also present you two of my patients that I found having that. And actually my last patient with this obsessive habit is 9 years old. So this one will be kind of interesting to show. Okay, do we have the slides? Wow, I'm lucky. Doesn't happen often. Let's hope not too long. Okay.
How many patients do you treat?
Actually,
Have you treated already?
with this, like mania, rhinotolexomania, I have 2 patients. But I have many patients with septal perforations, and I usually ask them, do they do that? And many patients, we don't ask them, and they do that. But when we are very, well, like, trying to learn more and more from their habits and ask them about their habits, it's getting more and more, and they say that in the adolescence they did it more often and it started then and they saw crusting in their noses. So I'll show you a few of my patients. One of them I decided to operate before I knew she was doing it, and then the problems recurred. There is this problem of recurring septal perforation in those cases. No more slides.
Taking the time to ask you something.
Yes.
Do you include patients that do nose picking with external objects like pencils?
During this presentation, no, I won't be talking about the foreign bodies. Yes, but I do see patients with foreign bodies in their noses. Yes, of course they can. They can, and there is this rhinolith that can form around the foreign body. Yes, it can also destroy the nose. Yeah, but it's also a rare thing. When speaking, well, in pediatric rhinology, when I used to work, I had many of these. In adults, I don't see the problem.
Okay, shall we carry on?
Yes. Concerning treatment of patients with Staph aureus, I only found that in healthy population, well, we don't treat the Staph aureus itself, the colonization, but we only find guidelines for treating the recurrent MRSA infection. And there are studies, they're limited, who do show the benefit of decolonization in several diseases, such as atopic dermatitis, Herm dermatitis, recurrent skin and soft tissue infections, and others. Further, I was laughing at picking the nose and doing a presentation on picking the nose, but I found this paper, and the title was Picking the Nose for Clues on Disease Pathogenesis in Vasculitis, ANCA-associated vasculitis. So, is it a light topic? Is it not important? I think there is something, especially that the same authors a few years ago wrote a very nice paper that patients with GPA, patients with vasculitis, are less capable of initiating a protective humoral immune response to Staph aureus. And although the exact role of Staph aureus in the disease pathogenesis is far from clear, it has been postulated that Staph aureus may induce a break in tolerance to PR3 or MPO in predisposed individuals by one or more of the following presented mechanisms. Among them, well, I think the oldest one that I've heard for many years is molecular mimicry, the third one. But the neutrophil extracellular traps, which is quite a new one, seems to play an important role, and there are studies in mice that have demonstrated the induction of ANCA upon injection of activated dendritic cells loaded with NET components. Yes, and there is the fourth hypothetical theory, which is an intriguing one, but described only recently, and the authors of this paper found that they called it co-capture, and it implicates that Staph aureus derived extracellular proteins and staphylococcal peroxidase inhibitor, they have a role in induction of pathogenic ANCA. Here, I would like to present some of my microbiome studies on patients with GPA. The first one is an example of a patient with stable disease with remission, and there is much less of Staphylococcus than in the second case, which was an active phase. And that's what we find in literature, that patients with GPA in active phase, they changed the microbiome. They have their microbiome changed. And there is much more, the higher abundance of staphylococci in those patients in active phase of disease. And these are some of the pictures which are probably you are familiar with, as long as they are patients with GPA and with crusting in their noses. There's also an endoscopy in one of my patients. But with this slide, I would like to end the part of rhinothylaxis and the role of picking the nose, the staph, and go to something which is, I think, more important during this presentation, which is the obsessive picking the nose. This is the true automutilation that we have to discuss. What I told up to this moment were hypotheses and things that we have to think about. And now, this is the true disease. And here, first, I will present you two cases that I found in literature. This is the case from 1997. It is a 53-year-old woman who was described with a long history of compulsive nose picking, presenting with a large self-inflicted nasal septal perforation and right-sided penetration of the ethmoidal sinus, or let's say ethmoidectomy. Another paper written by one of my friends, Shaz from Birmingham, they describe the case of medial wall erosion with an orbital inflammatory mass as a resultant lacrimal obstruction secondary to rhinothylaxomania in a 67-year-old male with known history of compulsive nose picking. The examination in this patient showed that there is blocked right inferior canaliculus. Nasal endoscopy showed a large nasal septal defect with multiple areas of crusting and bleeding. All the investigations, I mean hematologic investigations, were normal in the patient, and CT showed the changes as we see on the picture. In histology, they didn't find anything, and the nasal mucosa was reactive inflammatory with a surface covered with gram-positive cocci. And here, I present my case, my 9-year-old patient. Actually, it was a, I'll stop it. Yeah. This is the 9-year-old girl that I was taking a biopsy from her nose. She was actually having a history of dermatitis, atopic dermatitis, and she was referred to allergology, pediatric allergology, and they saw the changes in her nose and asked me if I can help with her and tell them what to do in such a case. She was a difficult case to me. Of course, everybody was suspecting bad things, like maybe in a young patient GPA. We can think about it. Actually, we have 10 patients, pediatric patients with GPA that we follow up. We also had to take the biopsy to exclude neoplasm. And then, at the end, it was recently that I received the pathologic examination result. There's nothing in it. We did all the infection panel, so we examined the child with everything we can, and we didn't find any reason apart from some behavioral problems. And now she's under the she's being consulted by psychiatrists and psychologists to see how can we help her. And it's her. I also have her endoscopy. This is the flexible endoscopy. We were checking if the ostia of the maxillary sinus are patent. Well, there was a huge destruction in her nose. We saw that this is the maxillary sinus, which was obviously we could pass and go in it. Okay, let's go to the next slide. And this one is an adult patient, also one of my patients. She had a history of occupational exposition to bleaches, but this condition appeared after she retired. And this is her MRI. Yes, slowly, but we will see soon, a large cavity on the right side with septal perforation. There is one thing combining those two cases, they were both coming and seeing ENT specialists due to preseptal complications. I mean, they had eyelid edema in the course of what happened. They also complained of facial pain. So the reasons why the patients like that visit the specialist, visit us, is mostly, well, important, right? Connected with sinuses. And from practical point of view, when I think what I can do, how can I help those patients? Because, well, the behavioral treatment and the psychological referral is important, but what can I do? And what I did to this female, I had to reopen her maxillary sinus, as the ostium, natural ostium of the maxillary sinus was destroyed and was in adhesions. And as we saw in MRI, it was filled with mucus. So we had to think about it. But another important thing is, if those patients develop CSF leak. We saw that the damage is huge. Actually, in this patient, for a while, I saw pulsation in the roof. So we have to follow up them for the possibility of CSF leak either. Okay, and going further, yes, when searching the literature, I also find this chronic rhinothylaxomania, an interesting case of an 60-year-old female who had multiple infection sequelae, who was infected with multiple times of recurrent sepsis, meningitis, endocarditis, cystitis, and most commonly she was her culture was positive with Staph aureus. And there were also cases described as manifestation of empty nose syndrome. So those patients may also come to you and say, we cannot breathe through the nose. I have a trouble with breathing through the nose. And this is a nice slide to show summing up what are the main problems of those patients. And the main symptoms that they come to us are crusting, epistaxis, epiphora, hyposmia, and headache. This slide also shows how many treatment modalities were used. And usually on the first place, we see behavioral modification. So it's not us, right? We have to cooperate. We have to have a different center, somebody that we can send our patient. But we can do sometimes, in certain cases, surgical intervention. And we see here some of the authors describe that they did frontal sinusotomy, maxillary antrostomy, apart from all those others who started with behavioral modifications. We also use local treatment. We also use ointments, nasal rinses to help those patients. In some, we can also find a benefit with vitamin B in ointment. It was said that vitamin B is kind of good in neuropathic itch. If those patients say that it's itching them in their noses, it's a possibility to use vitamin B. And here I will also present those cases that I mentioned before with septal perforations. Actually, this is one who admitted that she was doing it in her adolescence commonly. That's a quite small perforation anteriorly in the anterior portion of the septum. Another one, not yet the perforation, but the crusting in the nose and the changes, metaplastic changes on the mucosa. And the last one, I'll stop this one and this one. And the last one, it is my patient after the reconstruction with a flap of her septal perforation, but she continued on picking her nose, and this was the result. I was a little bit afraid that it will reperforate, but we discussed it and actually tried to treat it locally, and eventually it is now much better. Okay, let's stop it and go further. Okay, but Speaking of rhinotoxomania, we also have to cover some important psychiatric diseases. And some of them were already discussed during this conference, especially during the lectures on rhinoplasty, because there is this body dysmorphic disorder where we see that one of the symptoms is skin picking, and this skin picking can be connected with the nose. This term, dysmorphia, which is a part of the body dysmorphic disorder, also comes from Greek and means ugliness. That's interesting, how many interesting things we learn here in Greece. And other cases that were described with psychiatric disorders are ADHD, where treatment induction followed the control of the nose-picking behavior. There are also papers describing rhinotoxomania in schizophrenia. And now I'll end my lecture with trophic trigeminal syndrome, the last disease that I will cover in udder mutilation part of this session. The disease process in this syndrome involves self-manipulation and destruction of the nasal region, usually following stroke, denervation of the trigeminal nerve, or treatment of trigeminal neuralgia. The clinical features of the disease typically involve one or more painless ulcers in the alar region. More severe cases can involve tissue loss and may spread to the cheek and upper lip. The tip of the nose is often spared because of a different innervation from the medial branch of the anterior ethmoidal nerve. And the latency period between the damage of the sensory nerve fibers and the appearance of the lesions is variable, ranging from weeks to decades. Patients of various ages have been documented, ranging from 14 months up to 94 years, with a mean of 57 years. I also found a paper on this trigeminal trophic syndrome written by the president of this ERS meeting. That was interesting. Locally, those patients present with hypoesthesia or anesthesia, loss of trigeminal nerve reflexes, and overall neurological findings depend on the territory that is involved, stroke or injury. There are also non-trigeminal facial neuropathic itches that can indicate lesions of the nervous intermediates in the cranial nerves, such as facial or glossopharyngeus. TTS must be differentiated from other causes of facial ulceration. Again, we have problems, so I'll just say, yeah, okay. From other causes has to be differentiated. We have to take biopsy to exclude carcinomas. We have to think about pyoderma, Wegener's, deep fungal infections, tuberculosis, or others. And my last slide, well, almost last slide. We have to think carefully about those patients. A multidisciplinary approach should be utilized, and it should include neurologic evaluation of those patients, pain management, medical treatment, and also surgical repair, psychological management to assist a reduction of self-manipulation. Crucial element of the treatment involves education of the patient, and well, to show how the underlying cause causes the ulcers, and convince them that lesions are self-induced. It has been shown that when regional flaps are used, the long-term results have been quite good. A successful repair is commonly described when we use the paramedian frontal flap, and this one is recommended by most authors. If local flaps are used from adjacent areas of the face, the anesthetic result is not that good, and repair tends to shrink and develop recurrent ulceration. There are some studies that we can use topical ointments combining amitriptyline and ketamine, or we can even use topical capsaicin to treat the neuropathic itch in those patients. But usually they are oral medications that we use. And from the pharmacological point of view, the best sound to be sodium channel blockers such as carbamazepine, or and next are others that I use are gabapentin or pregabalin either. Other drugs that have been shown to have limited benefit include diazepam, chlorpromazine,
It's COVID.
Just a simple question. Most nasal ointments are not absorbable and are not tolerated when once aspirated. Do you fear that somehow it gets aspirated and then in the end may cause lung disease?
I've never
or
had
something?
problems with aspiration
Of
of an ointment. I've never heard of a problem with that. So I use locally. Actually, I don't talk too much of that, but I treat those patients a little bit differently as long as we suppose there is dysbiosis in those patients. I use probiotics in their noses. I like them. I enjoy the results, less crusting. It's hard to prove that they are, well, they do not treat the disease itself, but they are helpful locally. So this is the thing that I found, well, interesting and helping in those patients.
Yeah, hello, thank you for your lecture. It's really nice to hear. I came in a little bit late, so you might have mentioned it already. But sometimes it's more a remark than a question. For diagnostics and also to give the patient a solution, by Wiske-Fokkens we're also thought to sometimes just block the nose by putting in a mirror cell. Because if after 2 weeks, you remove the mirror cell, you have to give a little antibiotic, of course, you remove the mirror cell and the crusts are gone, the patient wasn't able to get there with the finger or any object. This might also add to your suspicion of having a nose pricker instead of EGPA, for example.
Yeah, thank you.
Thank you for a nice lecture. It's just like a comment of what we do in Mexico, but not ENTs, but there's this tradition of when a child are picking their nose, to rub them some chili in the tip of the nose.
Capsaicin.
Yes,
I mentioned.
exactly. And so the children start picking their nose, and it itches them so much, and they start crying, and they leave the habit. Do you have the equivalent or something? Have you ever thought about something?
We can have it. We can explain it as long as we know that capsaicin, it hurts in the beginning, but later on it opens the channel, it opens the TRP channel, and it stops working. So there is an explanation that later on, in the beginning it burns, but later on it helps, the same as with non-allergic rhinitis.
Exactly. Thank you.
Someone might think this is a child abuse. Okay, it depends on the country. So we won't do a rhinoplasty in these patients. Rhinoplasty. Rhinoplasty. I'm sure these are the worst candidates. Let me ask you if you've noticed an improvement. One solution was to put the Merocel for 2 weeks. Okay. Yes. If you've seen with the psychiatric intervention, did you see that if you stop nose picking, then all the crust will go at some point?
Well, at some point, those who were describing the paper on ADHD in a patient and child, they did see it. So when they started treating the patient, the nose picking was like lesser. Yeah, the habit changed. So it was the question, right?
That was a question, yeah. Okay. Thank you very much. Are there any questions? Okay, thank you.
Thank you.
Let's carry on with the next one.